Welcome to Module 2 of the Florida Perinatal Quality Collaborative and Tennessee Initiative for Perinatal Quality Care Buprenorphine Training for Obstetric Providers. I am Dr. Jessica Young, and I am board certified in both OBGYN and addiction medicine. I am the Maternal Medical Director for the Tennessee Initiative for Perinatal Quality Care and the Maternal Medical Director of the Firefly Maternal Recovery Program at Vanderbilt University Medical Center. I have worked with pregnant and postpartum women with opioid use disorder for 10 years. I started my work with this population as a generalist obstetrician, incorporating this care into my regular OBGYN practice, and quickly moved due to clinical logistics to having one half-day clinic session a week devoted to seeing pregnant people with OUD. I now devote all of my clinical practice to the care of women with OUD. While this work has evolved for me into being much more than I ever anticipated, I want to assure you that you can incorporate this work into your practice in a variety of ways. I have several colleagues who have a small part of their practice focused on OUD in pregnancy and spend the rest of their clinical time devoted to other pursuits. I have no disclosures. Why would an obstetrician prescribe buprenorphine? Number one, opioid use disorder is a significant cause of maternal mortality. Number two, obstetricians manage lots of complicated conditions in pregnancy. And number three, many people with OUD are reproductive age females. It makes sense that we would manage a condition that has such a significant impact on maternal and infant health. As OBGYNs, we manage a lot of complicated conditions in pregnancy. For those of you who are maternal fetal medicine specialists, you manage even more complexity. Unfortunately, many of us have limited education on substance use disorder in medical school and even less training on management of OUD in residency. I think this lack of training holds us back from incorporating substance use disorder treatment into our practices and probably even more harmfully keeps us from screening adequately for substance use disorder in pregnancy. Identifying a problem that we have limited options for treatment is a barrier to implementing recommended screening. What if you identified a pregnant person with OUD, referred them for inpatient treatment, and were able to welcome them back to your practice where you continued their buprenorphine for the duration of their pregnancy? This simple act of prescribing buprenorphine could be life-saving and start a family on a healthier trajectory. From Module 1, you know the impact of OUD for pregnant people and their neonates. You also know about the treatment options we will be focusing on in this module and how you actually go about prescribing buprenorphine in pregnancy. Our three key ideas for this presentation are buprenorphine management in pregnancy, models of care, and case examples. Let's focus first on buprenorphine management in pregnancy. How do you get someone started on buprenorphine, and how do you maintain them on this medication? For buprenorphine management in pregnancy, we will be talking about initiation or induction, stabilization, maintenance, dosing changes in pregnancy, postpartum buprenorphine management, and harm reduction. When we are starting someone on buprenorphine, while the basic principles are the same in terms of the necessity of the first dose requiring the patient to be in withdrawal, the setting makes a difference in how the induction happens. Regardless of setting, patient education is important. Informed consent for medication for opioid use disorder in pregnancy is necessary, and a patient contract is an important tool. So who needs inpatient induction onto buprenorphine? Overall, anyone who is unstable would need inpatient induction. For those who are pregnant and also dependent on alcohol or benzodiazepines, it is recommended that detoxification from those substances happen at the same time as induction onto buprenorphine. Someone who is having a psychiatric crisis, such as suicidal ideation or hallucinations, would necessitate a buprenorphine induction inpatient. A good rule of thumb is for all third trimester buprenorphine inductions to happen inpatient. This way, if there is precipitated withdrawal, we can intervene and stabilize quickly. We can also do buprenorphine inductions while a patient is admitted for other reasons, whether that is preterm premature rupture of membranes, preterm labor, or complications of opioid use disorders such as endocarditis. Buprenorphine can also be started postpartum after delivery. It is not uncommon for pregnant people to present to labor and delivery with limited or no prenatal care. There can be many reasons that someone wouldn't seek prenatal care, including stigma and fear of legal repercussions, and being able to offer treatment for opioid use disorder at the time when a woman is accessing care can be life-saving. For inpatient inductions, there are several important elements. First, we want to know estimated gestational age. If dating of the pregnancy has not already been done, this needs to be done as part of the initial assessment. For some institutions, this might affect where buprenorphine induction can happen in the hospital. We want to know that the pregnancy is viable, and this can be accomplished by ultrasound, fetal heart tones, or fetal heart tracing, depending on the gestational age. Of course, we want to take a good medical history, including substance use history and mental health history. Labs that are necessary include urine toxicology, including buprenorphine, prenatal labs if needed, hepatitis C testing, and a complete metabolic panel. The clinical opioid withdrawal scale is important to be administered to know when it is less likely for the test dose of buprenorphine to cause precipitated withdrawal. These are elements of a medical history that can be very helpful in terms of shared decision-making for opioid use disorder treatment and if the patient is a good candidate for buprenorphine therapy. A substance use history includes substance type, history of use, past treatments, and history of overdose or other complications from opioid use disorder. A mental health history is also important because co-occurring mental health disorders can make OUD difficult to treat. Understanding a patient's social determinants of health is also helpful. Understanding if they need housing, transportation, or domestic violence resources can be helpful in discharge planning, particularly if residential treatment is necessary. This is an example of a flow chart for buprenorphine medication-assisted treatment induction in pregnancy from the ASAM buprenorphine waiver training. On your right, you will see the inpatient branch. Reminder, in order to give the test dose of buprenorphine, the patient must have a CAL score of at least 10 to 12. Usually this means they need to abstain from opioids for at least 12 to 24 hours, sometimes longer if they've been using fentanyl. You start low with 2 to 4 milligrams and then increase to maintain symptom control. For example, you can give 2 milligrams every 2 hours with the goal of 8 to 12 milligrams in the first 24 hours. This is an example of another basic algorithm for buprenorphine induction in pregnancy. You need to wait for a CAL score of greater than 10. Give a test dose of 2 milligrams. If no precipitated withdrawal, give buprenorphine 2 milligrams every 2 hours for a max dose of 8 to 12 milligrams in 24 hours. On day 2, you would give the total dose of buprenorphine that was given in day 1 in the morning and continue to titrate up as needed. Typical stabilization doses will be 16 milligrams, but some patients will be fine with lower doses and some will need up to 24 milligrams. If you give someone 2 milligrams of buprenorphine and they have precipitated withdrawal, you have 3 options. Number 1, you can give them an opioid agonist such as hydromorphone and go back to step 1. That is, wait for the CAL score to be greater than 10. Though you will likely want it to be higher, assuming you waited until it was greater than 10 the first time. Number 2, continue titration up of buprenorphine with comfort meds. Or number 3, switch to methadone. This would mean giving 10 milligrams of methadone and titrating up. Additional comfort medications are often needed to get people through acute withdrawal symptoms. Agitation and anxiety associated with withdrawal can be helped with clonidine. Sleep disturbances can be addressed with trazodone or Seroquel. Frequently, people having withdrawal will complain of muscle aches. Tylenol should be utilized for this, as well as NSAIDs when not contraindicated by stage of pregnancy or other medical reasons. We are really good at addressing nausea in pregnancy as obstetricians. For diarrhea due to withdrawal, loperamide can be given. This is an example of an electronic health record order set for buprenorphine induction. It has orders for vital signs, the CALS assessment, nursing instructions about precipitated withdrawal, and common comfort meds. This order set has the nurse inform the OB physician of the total dose of buprenorphine given in the first 24 hours so they can order the day 2 dose. Admission and discharge order sets or panels can also be helpful. This is an example of a discharge order panel for the pregnant or postpartum patient with OUD. It includes naloxone education and prescription, smoking cessation aids, and outpatient referral appointments. There are times when you will want or need specialist consultation. In your setting, that might be addiction medicine, addiction psychiatry, or general psychiatry. This list is not meant to be exhaustive. Patients with current methadone use will take longer to get into adequate withdrawal to start buprenorphine and are at a higher risk for precipitated withdrawal. This is true also for patients using high doses of fentanyl. Anyone who is also detoxing from alcohol or benzos will need treatment that focuses on safely tapering off those substances. Pregnant people with other severe psychiatric conditions will also need specialist consultation. We are now going to move on to the outpatient setting. Again, this will be appropriate for someone less than 24 weeks of pregnancy or postpartum. Some of you may choose to never start someone on buprenorphine as an outpatient. That is completely fine. You don't have to be doing outpatient inductions in order to incorporate buprenorphine into your practice. However, if you are able to, this can increase access to buprenorphine for those who don't have a contraindication to an outpatient induction. A plus is that this is more accessible to some people. The con is that it may be difficult logistically, as well as challenging to get the patient to the dose they need in a timely fashion. An outpatient induction happens over several days by necessity. It is rare that a person will be in sufficient withdrawal to start buprenorphine at their first visit. At the initial consult, we want to cover the same medical history components that we discussed in the inpatient induction. We also want to determine estimated gestational age to make sure they are a candidate for outpatient induction. We obtain urine drug toxicology to make sure they do not have concern for methadone use or benzodependence. This is also a good time to obtain the informed consent and patient contract. The second visit would be when the buprenorphine induction is actually started. They are instructed not to use opioids in 12 to 24 hours, and a CAL score is done when they present, as well as urine toxicology. If their CALs is greater than 10, a test dose of 2 to 4 milligrams is administered. If tolerated, an additional 2 milligrams can be given every hour while in clinic, as needed for continued withdrawal symptoms. A prescription is given for the patient to fill, for them to take the total amount that was given on their first day of induction in the morning of day 3. On day 3, the patient comes to clinic having taken the home buprenorphine prescription they were given to take for that morning. We evaluate symptoms and cravings and increase the dose by 2 to 4 milligrams. You are continuing to do urine toxicology daily. They are then given the prescription for the total dose that was given that day to be taken the following day. Day 4, the patient takes their AM dose and is evaluated for symptoms and cravings. The dose is again increased by 2 to 4 milligrams as necessary, and a prescription is given for 3 to 7 days for the total dose until the next visit. This is a flow chart for an outpatient buprenorphine induction. If you precipitate withdrawal with your test dose, referral to inpatient is necessary. Regardless of site of induction, informed consent to buprenorphine treatment is important. Risks include nausea, vomiting, or constipation. Of course, these are symptoms that are often seen in pregnancy alone, but buprenorphine can make these symptoms worse. Withdrawal, if buprenorphine is stopped abruptly, is also a potential side effect. Buprenorphine can cause overdose combined with other substances. Another risk is NOWS or NAS. I typically counsel patients that the general risk for this is 40 to 45%, but could be lower or higher depending on your institution and whether rooming in and other supportive measures for opioid-exposed newborns are employed. There are also potential long-term neurocognitive effects for the infant. I discussed that currently the data on this is mixed, but that ultimately it is safer and healthier for the fetus and infant for mom to be stable in recovery. The benefits of medication for opioid use disorder or medication-assisted treatment are equally as important, including decreased risk of overdose, more engagement in recovery, decreased risk of complications from opioid use disorder, such as endocarditis, abscesses, and hepatitis C exposure. We also see less foster care placement if mom is not relapsing and is stable in their recovery. A patient contract can be helpful so that the patient knows what to expect from you and what you require from them. This can address regular urine toxicology, frequency of visits, required group or individual therapy, the process for lost or stolen medication, consequences for overusing, sharing, or selling medication, being on time for visits, or any other items that you feel it is important for the patient to understand. We also discuss safe storage of medication and the overdose risk for children if they ingest buprenorphine. Once you've successfully started someone on buprenorphine, they move to the stabilization phase. Frequently, dose adjustments are needed in this phase. We do weekly visits in the stabilization phase. This allows for us to intervene more quickly if a patient isn't doing well and recommend a higher level of care. This also adds some accountability of frequent drug tests and visits. Reviewing your state-controlled substance database is recommended with each buprenorphine prescription and may be required by your state with each prescription. Encouraging engagement in support groups, group therapy, or individual counseling is an important part of treatment. If you do not have these services in your clinical setting, building community partnerships and referrals out to these resources are crucial. Once someone has demonstrated stability in the stabilization phase, they can move to the maintenance phase. We generally see pregnant people in the stabilization phase weekly for at least a month. If they are doing well at that point, they can progress to every 2-week visits. If they do well with this, they can progress to once a month prescriptions. Notice I do not say visits. Their visit frequency will also depend on their stage of pregnancy at their buprenorphin induction. For those in the maintenance phase, dose adjustments may still be necessary. This is a good time to talk about dosing. Typical doses range from 8 to 16 milligrams. However, due to metabolism of pregnancy, especially as pregnant people move into the late 2nd and 3rd trimester, doses of 20 to 24 milligrams are sometimes needed to prevent relapse. To prevent cravings, the buprenorphin plasma level needs to be at or above 1 nanogram per milliliter. This chart shows the hours that were below 1 nanogram per milliliter for doses from 4 to 12 milligrams during pregnancy, trimesters, and postpartum. We also know that people who use high doses of IV heroin or fentanyl tend to need higher doses of buprenorphin to stabilize. We also see this for pregnant people with co-occurring chronic pain. This next slide shows the predicted mean concentration time profiles at steady state following administration of 8 milligram sublingual twice daily buprenorphin during 1st trimester, 2nd trimester, 3rd trimester, and postpartum in 100 virtual female subjects spread across 10 trials. You've prescribed buprenorphin during pregnancy and they've delivered a healthy baby. Rooming in was supported by your pediatric colleagues. She is breastfeeding and mom and baby have been discharged home with a therapeutic plan of care. What next? When adding buprenorphin, medication-assisted treatment, or medication for opioid use disorder to your practice, a question to ask yourself is how long will you prescribe for your patient? 6 weeks? 12 weeks? 6 months? A year? Indefinitely? I don't think there is a right or wrong answer to this. I started out prescribing for 8 weeks postpartum, then moved to 12, and now we care for women for at least a year postpartum. In many obstetric settings, it would make more sense to transfer a patient out earlier postpartum. Ultimately, the most important thing is that you have a plan and a referral source. Unless you are the rare obstetric practice that can incorporate MAT, MOUD patients into your practice indefinitely outside of the pregnancy context. In order to facilitate your postpartum referrals, know your referral sources and make friends with your MAT providers in your community. Identify physicians or practices that you will refer to and solidify that referral process with that practice. Make sure the patient is linked to that practice several weeks before the time when you want the transition to happen. An essential element is educating the patient about this transition, the earlier the better, so that they can mentally prepare for the transition and know what to expect long term. Opioid use disorder is a chronic medical disease. Like all chronic diseases, relapses happen. So what do? Stop care? Fire the patient? I would say no. For our diabetic patients who don't follow their diets, we increase their insulin, get them nutritional counseling. Opioid use disorder requires that same intensification of resources. Relapse is an indication that the patient is struggling and more resources and support is needed. This might mean moving a patient back to weekly visits and/or increasing their buprenorphine dose. This might mean they need a higher level of care, which could include referral to an intensive outpatient program or a residential treatment program. This is another time when it is extremely helpful to know your community resources. I'm a big believer in harm reduction. If we can save someone from overdosing, then they still have the opportunity to live a life not defined by this disease. We reduce harm by prescribing naloxone for overdose prevention and educating patients on how to use it. Safe storage of buprenorphine is another part of harm reduction. This decreases risk of medication being lost or stolen or accessed by children who can overdose from small doses of buprenorphine. A large percentage of pregnant people with opioid use disorder smoke cigarettes or vape. By offering smoking cessation resources and programs, we can help them reduce the risk of NAS NOWs and other complications of tobacco use in pregnancy. Some patients continue to use during pregnancy, including IV drugs. If needle exchanges are supported by your state and local laws, then referrals to those agencies can help our patients avoid infectious complications of IV drug use. Relapse is a part of opioid use disorder, just like asthma attacks are a part of asthma. The more we can help a pregnant person navigate a relapse in a way that keeps them engaged in care or re-engages them in care, the more likely we are to improve their long-term outcomes. We've talked about how to start someone on buprenorphine and what makes up the stabilization and maintenance phases. Let's talk about some examples of different models of care and how you can incorporate buprenorphine prescribing into your practice. I've put these into 3 categories. The first, a bridge to stabilization. The second, combined obstetrics and OUD. And third, an obstetric OUD treatment program. The first model is a way to stabilize someone on buprenorphine in an acute care setting with a bridge script to get them into another treatment program. You would do your inpatient induction onto buprenorphine, whether prenatally or immediately after delivery, and then refer them to a community addiction medicine specialist. Of course, you would ensure that they have ongoing obstetric care as well if they are still pregnant. This model is good for emergency rooms, hospitalists, a setting where outpatient capacity within your obstetric clinic is limited for buprenorphine prescribing, but there are accessible outpatient addiction medicine providers. This might work well in large health systems with outpatient referral sources or within academic medical centers. In order to do this well, you need outpatient MAT, MOUD resources. You also need case management to ensure patients get to their outpatient appointments. Being able to have a warm handoff between inpatient and outpatient teams is super helpful and helps break down silos that we commonly have. You would need to train your inpatient staff on topics pertinent to opioid use disorder and pregnancy, such as the clinical opioid withdrawal scale or COWS, buprenorphine inductions, stigma, and trauma-informed care. For the combined obstetric OUD practice, you could implement this in a variety of ways. You could have both inpatient and outpatient inductions onto buprenorphine, or you could only prescribe for pregnant people once they are in the stabilization or maintenance phases. This usually means prescribing buprenorphine during pregnancy and then transferring out at some point postpartum. This is really for anyone with an outpatient practice with the willingness to incorporate this care into your practice. You could be a generalist or an MFM. You could be in a private, academic, or even a community healthcare practice setting. In order to do this well, you want to educate your entire staff, from the front desk to the person scheduling your appointments, from your nurses to your fellow obstetricians. You really need 2 physicians that have their X waivers so that there are no issues during vacations or other leaves. These can be the new NOI waivers that don't require the 8-hour training as long as each person isn't prescribing for more than 30 patients. You will want patient education resources, and there are resources available from your PQC, ACOG, AIM, and SAMHSA, to name a few. Urine drug testing is necessary. It is helpful to be able to do rapid tests on site, but not essential. Some practices may be lucky enough to have social work, case management, or counseling services on site. However, if not, you can still provide MAT, MOUD services with the psychosocial supports needed by partnering with a private therapist, local counseling center, and/or case management services through managed care organizations. Within this model, one can either devote entire clinic sessions to this patient population or incorporate these patients into your regular clinic sessions. This will largely depend on volume. Having a dedicated clinic session or sessions is very helpful when it comes to outpatient inductions and being able to devote more time to deal with the various complexities that can arise. However, having a dedicated clinical session is not critical and may not make sense if you are only caring for a few patients at a time with OUD. The third treatment model is the Obstetric OUD treatment program. This is ideal for a larger volume setting where you have a large number of patients with OUD already delivering at your institution. Within this model, you can do both inpatient and outpatient inductions. You will likely become, if you aren't already, a referral source for the community. This model also lends itself to longer care postpartum. Who would do this model? Really, anyone with an interest in this population can do this, but completing the 8-hour X-waiver training would be necessary, as likely your volumes would exceed 30 patients at any given time. We tend to see this model more in academic settings. Just a reminder about the X-waiver. All prescribers of buprenorphine must apply for the X-waiver. For those just wanting to prescribe 30 or less, this only requires a notification of intent to prescribe to SAMHSA. For those wanting to prescribe over 30 patients, you have to do the 8-hour X-waiver training. I hope that this has given you some ideas about how you would incorporate buprenorphine prescribing into your practice. Let's move on to some case examples. Our first case is a 25-year-old G1 at 15 weeks EGA who has a diagnosis of moderate opioid use disorder and is already on buprenorphine medication for opioid use disorder. She has just moved from another part of the state and doesn't have a local buprenorphine provider yet. What do? Of course, you could refer her elsewhere and only take care of her prenatal care, but because you did this training and got your X-waiver, you have decided to prescribe for this patient. You obtain a urine drug test, you confirm the pregnancy, you obtain a release of information for her prior MOUD provider, you check your state controlled substance database. You give her education on opioid use disorder and pregnancy, as well as neonatal abstinence syndrome NOWS. You go through the informed consent process and have the patient sign your patient contract. You prescribe the buprenorphine at the dose she is currently on. You see her back in 1 week. Our second case is a 32-year-old G4 P2012 who presents to labor and delivery at 32 weeks and has a preterm delivery. Screening with a validated screening tool is done, and she reports intranasal heroin use. Her urine toxicology is positive for marijuana and opiates, and a controlled substance database is checked and shows a 3-day prescription for hydrocodone from 3 months ago. What do? Of course, you do all the routine obstetric things and postpartum things, but you educate her on opioid use disorder and her treatment options. You offer methadone or buprenorphin stabilization. She chooses buprenorphin. You give her the 2 milligram buprenorphin test dose when her COW score is greater than 10, and you titrate her up over her time in the hospital to 16 milligrams daily. You give her a referral to a local treatment program, and intake is scheduled there in 4 days. You give her a bridge script for 16 milligrams of buprenorphin naloxone for discharge. Both FPQC and TIPQC have resources that are available to help support pregnant people with opioid use disorder and to support you as providers. Checklists can be helpful, especially when introducing this care to a new team member. At TIPQC, we have a trifold opioid use disorder and pregnancy checklist that includes each trimester, intrapartum, and postpartum care. This is the first trimester checklist. There are also second and third trimester checklists. This is the delivery admission checklist. This includes discharge considerations such as naloxone, contraception, and breastfeeding support. Pain management during delivery is something many opioid use disorder patients have anxiety about. They fear their pain won't be adequately controlled or that they will be judged as being pain medication seeking. Implementing protocols or standard operating procedures for pain management for the opioid use disorder patient with your anesthesia colleagues can improve patient experience and set the patient up for success after delivery. Now it's time for you to decide how you will implement buprenorphine prescribing into your practice. You might ask yourself, what are my internal supports? Who do I need buy-in from in my institution or practice? What are my community resources? Who can I partner with? How long will I prescribe postpartum? In conclusion, we have talked about 3 phases of management of opioid use disorder. Those are initiation induction, stabilization, and maintenance. These can be incorporated into an obstetric practice, and there are several models of incorporating buprenorphine medication for opioid use disorder treatment into practice. Incorporating buprenorphine into obstetric practices can save lives and improve outcomes for pregnant people and their children. I hope you leave this training inspired to get your X waiver and make a difference for a pregnant person with OUD. It can truly be life-saving and life-changing. Once again, my name is Dr. Jessica Young. Please reach out to me for any questions or for any support. Thank you for taking the time to participate in this training.